We're now live.
Thank you very much, Kirsty. Good afternoon, everybody. Welcome to this meeting of the West Yorkshire Joint Health Scrutiny Committee. My name is Mike Lodge. I'm the Senior Scrutiny Officer for Calderdale Council and provide support to the Joint Scrutiny Board. I'm starting the meeting as the first item on the agenda, as it's the first meeting of the municipal year, is to elect a chair and deputy chair. So if we can move to that item, can I ask members if there is a nomination for the chair of this Joint Scrutiny Board Committee? Councillor Hutchinson.
Thank you, Mike. Yes, I'd like to nominate Councillor Smage as chair for the coming year.
Thank you. And is there a seconder for that? Is that Councillor Addy seconding? Are there any other nominations for chair? So thank you very much. So could I ask all those in favour of Councillor Smage being elected as chair, just to put a hand up somehow? And anybody against? Okay, that's carried. Councillor Smage, do you want to take over the election of deputy chair?
Okay, thank you. So we need to elect a deputy chair as well. Is there anybody who would like to nominate a deputy chair? I would like to nominate Councillor Hutchinson. Is there anybody who would like to second that? Or...
Second that, Chair.
Thank you, Councillor Rhodes. Are we all in favour of Councillor Hutchinson being deputy chair for this year? Yeah, thanks ever so much, members. Thank you. Thank you. Okay, so now we move to substitutes nominated for this meeting. Are there any substitutes, Mike, for the meeting?
There are no substitutes, but I have apologies from Councillor Blagborough and Councillor Scopes.
Okay, thank you. I wondered if members would like to introduce themselves. So if we go in the order that you're on my screen, so Councillor Hutchinson.
Councillor Colin Hutchinson from Skirkerton, Calderdale.
Councillor Coates.
Hello, I'm Councillor Coates from Bradford Metropolitan District Council. Thank you.
Thank you. Councillor Addy.
Hi, I'm Councillor Beverly Addy. I'm from Kirklees Council.
Councillor Jamil.
Hi everybody, Councillor Rizwana Jamil and I'm from Bradford.
Councillor Rhodes.
Hello everybody, Betty Rhodes, Councillor, Chair of Social Care and Adult Care in Wakefield.
Councillor Soloway.
Councillor Andy Soloway from North Yorkshire Council.
Councillor Lee.
Good afternoon, Councillor Andrew Lee from North Yorkshire Council.
Councillor Swift.
Kevin Swift from Wakefield.
And is the Councillor Anderson?
Sorry, Chair, I'm just getting my buttons sorted out. I'm Councillor Caroline Anderson. I'm Leeds City Council Shadow for Adults and Health. Thank you.
Thank you. Have I missed anybody? I've got everybody. That's great, thank you. And I'm Councillor Smage from Kirklees. Right then, so the items on today's agenda are being held in public and this meeting is being webcast. Are there any public deputations?
No, Chair.
Thank you. The minutes of the previous meeting, these have been circulated. They're the meeting of the 28th of February. Do we agree them as a true record of the meeting? Yeah, if you can indicate, thank you. Are there any matters that anybody wishes to raise from those minutes, or can we move on at this point in time? Councillor Hutchinson.
I think we've received the dental needs assessment that we'd requested from the meeting bar one, which does include some information about oral cancers, but not to the level of detail that might be helpful. So I think that if we can follow up on that, but I know that at our next, in the work plan, we're looking at the dental service next time, which should hopefully include the pickup and treatment of oral cancers.
Yeah, and Mike, did you want to come in?
Just to say that the delay in circulating the oral needs assessment was my oversight, and we had received it from Ian and his colleagues, and it was, so my apologies to the committee for that. That's
okay. Okay then. So if there are no other points, the dental needs we need as an item in itself. Councillor Hutchinson, I agree. Absolutely, yes. We move to item 7, which is the West Yorkshire Integrated Care Board Joint Forward Plan. I'm presuming, Ian, that you're starting this, are you? If members will take questions after we've had the presentation, and if members could use the raise hands function or indicate when we come to questions, that would be great. So Ian, are you starting it off?
Yeah,
or is it...
no presentation for this one, just a bit of a short overview of the paper which Esther's going to provide. Thank you.
Thanks, Ian, and thanks, Chair. Thanks for putting the time on the agenda today. We're really glad to be able to come and talk to you about the Joint Forward Plan. Unfortunately, as you know, and I think I explained in February when I last came, that the timeline for development of the Joint Forward Plan didn't quite match the democratic calendar, which unfortunately for us in West Yorkshire isn't the way we would normally do things. We would want to engage with you fully along the way. But if you will remember, I brought a copy of the draft integrated care strategy to you in February this year, alongside a discussion about the development of the Joint Forward Plan. We did touch on that at the meeting. As a reminder, the strategy itself is owned by the Integrated Care Partnership, so our partnership board for West Yorkshire, which is the wider group of partners across West Yorkshire, not just the NHS. But the Joint Forward Plan is technically owned by the Integrated Care Board. That's the statutory arrangements. So the Joint Forward Plan is designed to be the NHS elements of the strategy for West Yorkshire. But we don't really work in that way in West Yorkshire. It's really hard to be able to separate the two things because we do so much together as partners, and that's the way we absolutely want to work. But the statutory guidelines for ownership of those two different documents are that the Joint Forward Plan is owned by the Integrated Care Board. As I said, the timeline were really challenging. They started this process at the beginning of the year and had to have a draft by the end of March, and then a submission at the end of July, which wasn't ideal. However, this is just the first year of the Joint Forward Plan, and we will be doing this on an annual basis going forward as well. So we will build it into our ongoing engagement mechanisms. But we have done much of the engagement work with partners in place in the same way as our strategies built from Health and Wellbeing Board strategies. Our Joint Forward Plan is also built from local plans. So the document itself consists of 5 place plans, which respond to 4 different elements of work. They respond to the long-term plan, so the NHS mandate, the delegated functions from the Integrated Care Board, the 10 big ambitions that we have within our integrated care strategy, and then those local health and wellbeing board priorities that are unique to the strategies in place as well. The place plans themselves have gone through their own individual engagement and governance processes, so they may well have been to your own committees at place. They've been signed off by the ICB committees at place as well. Then there is that, what you've got in front of you today is the West Yorkshire wrapper. So that sets out the work that we're going to do, which has passed through our 3 tests of whether something needs the scale, whether it's something that sharing best practice will help, or whether it's just a wicked issue that we really need to resolve together. And therefore those things are carried out at West Yorkshire. So that's what's in the document today. But that document alongside the 5 place plans is the whole of the work of the Joint Forward Plan. So when I came last time, we were in the middle of the consultation, which is a statutory requirement again that we carried out that consultation, although I am aware that perhaps some of the other areas across the country approached it in a slightly different way, but we were really keen to make sure that we did that consultation, and future consultation will be built through our involvement framework that we have at West Yorkshire. There were 6 themes which came out of that consultation, which will not surprise you, and they're detailed in the plan. Access to services, in particular access to GP and dentistry services, tackling inequalities, which is at the heart of our strategy, coordination of services and really getting that truly integrated, joined up care, having the workforce needed to deliver the services for our people, which I know from previous conversations with you, that's come up in terms of workforce, poverty and the cost of living and the impact of that on health and wellbeing and access to health services as a result of cost of living, and then getting the basics right in our delivery of health and care services as well. So we've tried to really make sure those consultation themes are the focus of our plan and the work of both the Integrated Care Board and the Partnership Board as well. In terms of the Place and West Yorkshire elements of the plans, a big part of the work, a huge part of the work really, has been about how we knit the work together. So we've traditionally had sort of things happening at Place and things happening at West Yorkshire. They haven't always knitted in the right way together. So we've really spent a lot of time building those relationships, facilitating the opportunity for colleagues across places, West Yorkshire programmes, collaboratives and partners to come together to make sure that their individual areas really align well to each other and that in their totality tell the story of what we're trying to achieve. So the conversations and the connections have been really helpful in supporting sort of true integration really, and they're putting us on a really good foundation for making sure that we deliver these plans and that we have a really good improvement approach going forward to delivering the plans as well. You'll also see that at the end of the document, there are a set of metrics. We had really strong feedback from Partnership Board and the Integrated Care Board in terms of our strategy about having some really tangible metrics through which we will be able to monitor our 10 big ambitions. So we've tried to do the work around that. We spent a lot of time with individuals trying to get them to think about the impact. So what the experience of care is rather than just sort of counting sort of numbers of things. It was really important us to try and change that, and we've still got a lot of work to do on that, it has to be said. We are building trajectories for those metrics at the moment as well, so that we have something to measure against. So that also really having those metrics in place gives us a really good opportunity to be able to manage those discussions at Partnership Board and Integrated Care Board going forward, so that we can start to have some really meaningful system updates against those ambitions, so that it's not just the NHS talking about individual areas, but that it's a whole partnership approach to how we're trying to achieve the ambitions together and how we can really make a shift. So we have got a collective document now, the place plans have been going through their final bits of governance, and then they will be put onto our website as well. It is a live document. That was always the intention, partly because of the timelines, but partly because we want to be able to course correct naturally with this, and because we will be continually having to refresh this on an annual basis as well. So there are still opportunities to make changes to the document in small part. We do see this very much as part of our business planning cycle, and I think what we've tried to do, which wasn't sort of the direction of travel given to us by NHS England, but we've tried to build this and align this to our operational planning, so that we've got a really good cycle of how we do things, how we set our strategy, how we do our operational planning, and make sure that we link the Better Care Fund and winter planning and all of those things into a meaningful way of us being able to make sure we're delivering our strategy. So for example, our operational planning last year for 23-24 was effectively year one of our joint forward plan. As we start that operational planning at the end of the year again, that'll be part of year two of our joint forward plan. So it's not planning for us isn't a seasonal activity. It's going through the year and making sure that we align to planning processes of partners too. Then the last thing just to mention is that, as I said, a big part of this has been about how we work with people across our system, how we make better connections to people, how we can make sure that we're improving in order to deliver these plans. So we have also started building an improvement framework around delivering the joint forward plan and the strategy. We had the first of our quarterly improvement forums last week, where we brought people together from across the system, trying to really get as close to the front line as possible. I know we had a councillor from Kirklees, we've had people from acute trusts, mental health trusts, the voluntary community sector, a whole host of different people coming together to share different insights on their work, to try and share tricky issues, to bring some different perspectives and try and help move to improvement in a slightly different way. We're evolving as we go, and we're learning. We know we won't have that right in the same way we won't have the joint forward plan perfect this year. we're now in the opportunity to be able to really build on this and get a much stronger position next year and evolve around the improvement work as well.
All right.
So that's just a bit of an overview, and happy to take any questions.
Okay, thank you. So the document was circulated ahead of the meeting. Can we now open it up for questions? Councillor Hutchinson.
Yeah, thank you very much, Esther. Can I just ask, to start off with, who is this plan actually written for? Who is it aimed at? Is it the general public? Is it elected representatives like us? Is it the various members of the partnership who want to see the bigger picture? Because it really does make a difference. It's extremely variable in quality as you read through it, because it's obviously been contributions from different people. There's some really well-written sections, such as the bit on creativity and health, living with long-term health conditions, the section on cancer and end-of-life care. And then there's some really turgid, repetitive sections like primary care transformation, like access to dental care, like the urgent and emergency care programme, like the mental health and learning disability section, which are really hard going. They're full of repetitions, jargon, acronyms. You know, they're not, they don't, you need somebody who can turn it into plain English if it is intended for the general public and for sort of non-specialists like ourselves. So that was, you know, my first over point, and then I've got some more detailed things that I would like to raise.
Esther, do you want to come in?
Thank you, and thanks, Councillor Hutchinson. It's an interesting one, because really the document is for the organisations to illustrate, to work together on delivering the plans. What we have done, and I didn't mention this, is we do have some other versions of the document that are far more accessible and will resonate more with the public. So we have some easy read versions, BSL, and they're a little bit more straightforward in how we're trying to explain what we're doing. So those have been put together as well. But actually, just having your feedback on some of those sections and understanding how that's reading across is really helpful. As I said, we're going to have to refresh next year, so that's something that absolutely will take away. And I think although the timescales were really challenging this time, I think we've learned that there is a variety of sort of how people write and how things come together, and that's something we need to work on. I think the other bit of it is that some of those areas you've described that are really good, such as cancer, for example, they have to pull together their own plans quite regularly for detailed information and for members of the public. So everybody has different responsibilities and accountabilities to different parts of the system, and I think that also affects how people present things. But absolutely, that's something we know we need to work on, and I'll take that away and think about that the next time.
All right, thank you. Maybe it's an indication of how much progress is being made in some areas. Councillor Hutchinson, you wanted to come back?
Yeah, thanks. I mean, I do appreciate that you know, people don't want to be held hostage to fortune by saying things that are too specific, but I'm concerned about what is not mentioned in the plan. There's a lot about anti-smoking strategy. There is no mention anywhere about vaping, that we're getting our children hooked on nicotine and nobody is doing anything about it. And it doesn't feature in this. There's no mention of vaccination programs. And we know that the measles vaccination program is falling far short, particularly in communities at risk. The only mention of vaccination is COVID, flu, and pneumococcus, which are old age vaccines. There really does need to be a focus on getting the most we can out of vaccination, which has been one of the key public health preventative disease measures that have been introduced ever. Again, there's no mention about encouraging participation in national screening programs, which in certain areas of communities is very poor. There's no recognition or strategy for dealing with digital exclusion. even though we know that it compounds the socioeconomic inequalities that lead to health inequalities, it's all presented as a very positive thing, but it can't, we do need to have a strategy for the digitally excluded. There's no mention at all for services for misuse of people who misuse drugs, when there's plenty of scope. That's one of the major causes of death in young adults, and yet it isn't mentioned at all. When there's loads and loads of experience around the country in harm reduction strategies. One of the things that comes up whenever we discuss mental health issues is lack of access to timely access to diagnosis of neurodiversity. There's no mention of dual diagnosis services where people have both drug and alcohol misuse and psychiatric conditions, and patients are bounced backwards and forwards because the definitions of the service provision, they don't fit one, they don't fit the other, they need to be brought together. And my key question, and family centres also don't get a mention when we're really looking to try and improve the quality of life for the next generation. But I'm sorry that rapid diagnosis isn't being appreciated as being the key step. Until you can actually define clearly what a patient's problem is, you don't know whether you can relax and reassure them or whether you have to move heaven and earth to get them the best possible care as quickly as possible to get them treated. We know that there's a big shortage of diagnostic facilities in this country that's impacting on early diagnosis of cancer, but it also has an impact on the ambition to reduce antimicrobial resistance. We've gone, you're fighting against the current. If you're doing most of your consultations online, you can't take microbiology specimens online. We've centralized laboratory services so that there's a greater barrier to actually taking a swab or sample and getting it to the place that's going to test it. And the fact that we're looking at trying to get a maximum wait for first outpatient attendance of 65 weeks. That is a huge length of time if you're sitting on something that is serious and progressive. So get the diagnosis done quickly, then you can know whether you can relax or whether you really do need to move it. And I would really like to see an emphasis on diagnostic services as the plan develops. I'll stop there, but there's quite a few others because it's a big plan.
Yeah, Esther, and then I've got Councillor Rhodes. Thank you.
Thank you. And you might have a view on this as well. It's really tricky to not make a plan that says absolutely everything, which would then be a very, very long plan, but also getting the balance of having some of those things, those really important things right in there as well. As I said, some of the difficulty with the Joint Forward Plan is that it's about delivering the NHS elements of the plan, and some of what you've described there is sort of public health commissioning, but we do work really closely with them, and I think it's a fair call that some of those preventative stuff perhaps needs to be far stronger in the plan, and I would like to take some of that away and go and have a conversation with the leads. I don't think that's beyond the realms of possibilities of us through the next iteration of the plan at the end of the year, beginning of next year, for us to start to look at that in a bit more detail. The family centres, obviously that's links very closely to local authorities as well. We are doing some work at the moment on women's hubs as another part of that kind of work. So there is a lot of work underway. The digital exclusion, I need to remind myself what's in the plan around that, because that is a really important one. And if that's not in there, absolutely something that we need to make sure that we're addressing, because that applies to all services, doesn't it? It's a really important one. But Ian, I don't know whether there was anything else you wanted to add on that.
I mean, it's a really helpful list. It's really helpful to have a fresh pair of eyes, and to be perfectly honest, I think vaping's a great shout, actually, and I don't think we are doing enough on that. A lot of the others we are there is work happening. So the vaccination programme that we've got, there's a big focus on that. There's a big focus in the short term ahead of winter to maximise uptake of vaccinations that we think will help with winter. There's a wider point there around children's immunisations, and we know there's been a drop-off for whatever reason in uptake of children's immunisations since the pandemic, and we've got a vaccine board that is overseeing that work. As Esther said, there's a lot happening around things like digital exclusion. I think some of this is about how we emphasise it in the document, Councillor Hutchinson, rather than the work going on. Others are areas where we might want to look at whether we've got enough focus and priority behind it, and I think vaping is a good example of that.
Yeah, the concern is if they're not mentioned, then they get forgotten about.
Yeah, and I'd written vaping down as well. Absolutely, I think it's important. Is that? Can I ask? Is there a delivery plan that goes with this overarching plan? Because you say things are broken down into other areas. Is there a delivery plan that goes with this? Just quickly before I bring Councillor Rhodes in.
Yeah, so each of the areas of work that are contained within the joint forward plan will have, most of them will have their own delivery plans as well, with the detail sitting underneath that. And likewise for the place plans, they'll have their own delivery plans underneath there as well for each of their elements of the plan.
Okay, Councillor Rhodes.
Thank you, Chair. Hello, Esther. Nice to see you again. Fully supportive of the comments that Collins made about what's not in it, as opposed to what you see in it. I'm wondering how it actually relates to the issues that you identified, Esther, in terms of what you went out and consulted on. For instance, the two major ones that we all have across the patch are the GP still not seeing patients face to face, how long it is to get an appointment if one persists, and the whole issue of dental services. We have seen before the report, and it's still there, I understand, and I know Ian will know about this, where the dental services, we were made aware that there was £400 million of unspent money, unspent budget. We use forward plans in local authority and in other places. Now, the chair has indicated what I was going to ask in terms of what are the delivery plans. In our forward plan, we see a date for a delivery on a certain item. If there's going to be a delay, then that delay is itemised and reasoned why. That's the first thing. Secondly, I'm very concerned that we're getting fragmented in all of this again, because you actually said that each of the services will have their own delivery plan that they will, I'm assuming, monitor. Now, how does that fit in with your forward plan? For instance, we spoke about the 10 priorities. How does that fit in with your plan? Because if it doesn't, then there's no overall outcome to see where we're flagged bad, red, good, or indifferent. So we could finish up with plans of a forward plan here, there, a forward plan of somebody else, no correlation, no outcome-based information on the service delivery. And I think we really do need to have some more information on how this is going to be managed, particularly, which is good news to hear, that you're going to be doing them on a yearly basis. So if you don't feed in that information corporately, how's it going to come out what achievements have been made or outcomes in order to build on the next year's plan?
Am I okay to come back in, Chair? Yeah, okay.
Yep.
Thanks, Councillor Rhodes. I appreciate your comments, and some of them, I mean, in terms of the GP access and you know, the access recovery plans, as you know, are being developed over the summer and into the autumn. Ian, I'm sure, can update you on dental services, but there's a lot of work being done to manage some of the funding arrangements around dental services, to invest and to try and improve services. I completely agree with you in terms of trajectories, of monitoring them, of how everything fits together, and I perhaps haven't got across that, what we're trying to do about that in the right way. We've really tried to make sure that we've nested all of this in kind of like a Russian doll style way of making sure that things are built. So our plans are built from places and the place plans, but obviously they knit together with the West Yorkshire plans. So when I talk about other delivery plans, if I give, for example, cancer has a delivery plan they have to put together anyway, but what is in the joint forward plan is based around that delivery plan. What we have done with the trajectories is make sure that they
Can I just interrupt you a minute, Esther, because I don't know about anybody else, but I'm having a little trouble hearing. Christine, I think you've got your microphone open. Could you mute yourself just for a little bit, Christine Hughes? Or can the person who's hosting this meeting perhaps mute you? Because I think we can hear another conversation. That's great. Thank you. Right, Esther. Thank you.
Okay. So what we're trying to do is make sure that those trajectories, those metrics that are at the end of the plan, and as I said, we're building the trajectories so there are those targets as you described, so we know if they're off track. But what we're doing is we have an integrated dashboard that is being put together for the Integrated Care Board, and that really clearly pulls in that data, those metrics that are part of our joint forward plan, and the Integrated Care Board will be monitoring those I think it's every quarter they'll be monitoring those. So we will absolutely be able to monitor progress against this. That's really important, because when we come to refresh it at the end of the year, if we can't provide some evaluation on whether we're making a difference, both on a quantitative level, but also on a patient experience level as well, experience from populations, then it's going to be a meaningless exercise. We need to be able to know what's happening. So we've tried to nest everything in the right way so that there shouldn't be alternate plans happening elsewhere that don't all contribute to the whole. Obviously, we need to work through this, and over the coming year, I think we'll probably learn, and there'll be things that we might do slightly differently next year. But we've worked really hard to try and make sure that nesting will work in the right way, getting commitment from the place committees as well, that their outcomes frameworks really knit into the joint forward plan outcomes framework as well. So hopefully we will see some of that, but we will learn as we go in the next year as well.
Ian, did you want to come in? Ian, did you want to come in on this before I bring Councillor Rhodes back in, or is it your point?
Well, yeah, if I could. I mean, I think the point about alignment is it's the same people doing the work. So the person who's got the detailed maternity plan is the person who's contributed to this plan. And what we've got on our website is quite detailed sort of plans in relation to those areas. So the maternity plan describes how we'll deliver the maternity ambition, as well as a whole range of other things, the suicide plan does, the cancer plan does, and so on. I was just going to say a word on dental, if that's okay, Councillor Smager. Do you want me to? Yeah. So we recognise the incredibly challenged position that we've inherited on dental. We took on the commissioning of that service from April this year, and it's a real priority for the board to make inroads and make improvements in dental access across West Yorkshire, recognising that some of the issues that we face on dental are nationally solved, like the contract, and have been at least 20 years in the making. What we've done immediately on dental, and I'm not sure the 400 million figure, Councillor Rhodes, but our number's 6.5, we think. And what we've done is
it's in the report, about 400 million.
Yeah, so we've identified that we think we've got about 6.5 million, then that when NHS England was the commissioner would have been pulled back into the centre in NHS England and not invested on dental. And we've made a decision to sort of go at risk and plan to spend that money this year. Of that 6.5 million, I think we're putting about 4 million into additional urgent access schemes for people who have got urgent dental needs. We want to invest in services for homeless people. There's a really great scheme in Leeds for homeless people that we want to expand to Wakefield, Bradford, other places. We want to invest in oral health prevention, particularly oral health improvement and ill health prevention, particularly how you support, young people who may have, additional needs, autism, with their brushing. And we want to support community dental services, invest in community dental services, so we can, reduce the very long waits on that. So we've got a plan on the spend. We're also looking to expand the flexible commissioning scheme, which we've made start on in dental, which allows you to use some of the value of the contract and invest that money in a different way that we think will better meet people's needs in West Yorkshire. So we've got a plan for it. There's not enough investment in dental services. There's a contract that isn't great, and there's a workforce shortages. Retention is the big issue in dental. It's getting people to build an NHS career in dental services. So we'll be developing a workforce plan around that. I guess looking forward to having the conversation in November around that and get into a little bit more detail about what we are doing and what we can be doing. The other conversation we're having on dental is with the Department of Health and Social Care to look at how we can get the sort of the Yorks and Humber system actually is becoming one of the next cabs on the rank in terms of fluoridation. That's a long process, a complex process. We're not in a particularly good point in the political cycle to do that nationally in terms of potential elections. But again, that's the one big intervention you can make that will make the biggest difference, we think, in terms of public health and prevention. So that's in the scope of the work that we're doing as well. So, and like I said, like Esther describes, for each of these sort of headlines, there's detailed work happening underneath. There's a lot of content there, and I think how we plan the sort of these conversations over the next year to focus on the issues that are most relevant, I think would be welcomed.
Councillor Rose.
Thanks for that, Ian. It's been an ongoing situation, and the national picture, and we saw it on the television last week, of an elderly person who for years hadn't been able to get a dentist and was actually pulling his own teeth out. And that's a national tragedy for that to be happening, and it is happening. But welcome the report that we'll be looking at later on this particular issue. I'll come back to Esther. Esther, on the forward plan, you've just started, I assume. When does your year start and when does it end? And how have you targeted within that year, at what point you will be monitoring any achievements or the red flag coming up?
Esther, do you want to come in?
Yeah, thanks, Councillor Rhodes. So the annual year starts from April for ourselves. As I said, it's not helpful, the timeline that we were given by NHS England in a June, July end date, because we've just finished a plan that technically should have started in April, which is why we're very much of the view of we want to get it right, the foundations right, so that we're really running in a strong way on a business planning cycle from next year. But we are already starting to monitor things. We want to build those trajectories because we need to be really clear on what the ambition is that we're trying to get to in terms of the real tangible outcomes, and not just a broad ambition. We want something tangible. So that's being re-looked at, and Partnership Board will be having some conversations about that in September, amongst other things. But we will already be monitoring. So the ICB will be having an update against the strategy in September's meeting, and obviously the joint forward plan is in part delivery of the strategy. So they are already planned into our business planning cycle and how we will report back to the Integrated Care Board and the ICB board as well.
Okay.
Thanks, Esther. I think a message to the chair will be that I think we'll have to discuss this, how we get reports back at regular intervals.
Yes,
absolutely. And I would really welcome being timetabled in for sort of February next year for the next iteration as well. That would be really helpful.
We'll discuss that. Yeah, Councillor Addy.
Thank you, Chair. I'm also on the page of this digital exclusion problem. I know it is mentioned briefly in there, but when we're talking about taking things forward, I'm really excited about using all the digital innovations to improve healthcare, but fewer face-to-face consultations, I don't believe is the right way forward for us, because I'm an articulate, educated, verbose person, and I find it hard to do a consultation with my doctor on the telephone if somebody isn't giving the full information out. Those visual clues are so important, and they don't work on video the same. Somebody comes with one problem to a GP and actually there's another underlying problem, or they're actually got a problem that they're not prepared to bring that can be picked up. So many things have been missed by on the phone and digital and online e-consults and things. I think it's so important that we really do see if there isn't a way forward which includes more face-to-face consultations. If you need to have a quick update on your prescriptions, you can talk on the phone if you are confident. and things like that. But the GPs do not necessarily, and you're not getting the visual clues back from the GP that say carry on talking, that I want to hear more. It's so easy, especially if it's not somebody you talk to all the time, and that's another thing, because you don't always have the same GP, it's the person who's on that day. So I really think, and the digital exclusion is so important. I've been working with this for years and years, just when people were coming onto the internet. And that wasn't about your GP, that was just about accessing general information. So people are really getting left behind. I was also concerned about the lack of timescales, but you've covered that. And then the other point I was thinking about there's something on financial delivery that probably will come up later with everybody else, but the zero suicide, trauma-informed, working with community groups idea is great. But I mean, just in Kirklees alone, we've got the 1125 project for girls and women who've had trauma. It's floundering because it hasn't got funding. Platform 1, which picks up the slack from the IACT referrals, is floundering because it hasn't got funding. It's okay wanting to work with these people, but how's that going to work when they haven't got the money and they're already picking up the slack? Is there some way forward in this that's going to work with them to make sure they can keep going if they're going to be key to it?
Esther, do you want to come back in?
Thanks, Councillor Addy, and really important points that you've talked about there. In terms of the digital exclusion, as Ian said, there is a lot of work going on there, and perhaps that's something about how we're reflecting that in the strategy. It's a really important balance, isn't it? And I know in terms of primary care services, there very much is the consideration of making sure people still have that face-to-face as well as digital access. There's also the wider bits around that. We have some real benefits now. We've got sort of community pharmacy, ophthalmology and dental, because it means that we can perhaps make sure that we're helping a little bit better in terms of navigation. Community pharmacy has huge things that they can help with that will relieve some of the pressure from GP services and increase the opportunity for people to get in there. So I think it's perhaps just that it's not been reflected in the right way, and that's something that we will think about for next term. In terms of the funding, it's a really valid point, and it's really difficult to divert money away from sort of responding in services through to prevention, but it's something that is absolutely the direction of travel for the partnership. As part of the work we did on the engagement of the strategy, some of the conversations we had with the voluntary community sector were funding was quite understandably brought up. And actually there was a group of people who did feed into our finance strategy to try and really drive some of that investment and sustainability in the voluntary community sector. And that is a part of our finance strategy now. There is a section around that. So we are trying to make improvements, because there's no point us saying all of it in the plan, as he said, if we can't then live and breathe and deliver at that. So that absolutely is part of the work we're trying to do.
Okay, thank you. Councillor Addy?
Can I just come back? Sorry, there was a bit about finance. Am I okay, Councillor Smage, to ask? In the finance section, it says that there are significant non-recurrent measures that are essential to be able to put this into place. Are they nailed on? Have they been confirmed? Are we just living in hope that they're going to come and therefore this is possible?
I'll hand over to Ian for that question. I'm not so hot on the finance elements.
They haven't been nailed down, Councillor Addy, is the honest answer. We did the piece of, we've finished the annual planning work for this year, which ended in June time, and that the assumptions and the percentage growth figures that we got from NHS England on that identified that there is a medium-term financial problem for us. We've set up a transformation and financial sustainability group, which I think has met twice, could be once, and that will be developing those detailed plans. Again, that might be something that is worthy of consideration at this committee, but there's not detailed plans for that in place yet.
Yeah, if you can get an update, that would be great.
Yeah, you get an update. Yeah. Can I just ask as well? You mentioned about the consultation. You surveyed 203 people responded. Can I ask if you are looking now at how you can reach more people to get in feedback on these plans, please?
Yeah, absolutely. We're rolling that into our involvement framework. I have to say, Karen and the team, and when I say the team for communications and engagement, I mean communication and engagement colleagues she's worked with across the patch. That includes local authority communication leads as well. We're part of the dissemination of the consultation. So we really did go very far and wide, but we obviously need to think how we can do that better going forward. So that's part of the evaluation of the process and thinking about how we can make that better in other years. And obviously, councillors are a huge part of that, because you have that direct access with the public, and will be able to hopefully help us a little bit better.
Okay, all right. I think it's about people being given the information about this is about services. It's not in the abstract,
Yeah, can I just add? Sorry, Councillor Smith, I didn't mean to put across you there. So the consultation is one part of the evidence that we use to support the prioritisation. It's not the only source of insight that we get. So you might remember last summer we got a very significant document from the 5 Health Watch organisations across West Yorkshire with all of the insight that they had gathered from citizens on what's important to them. We have linked to our maternity programme. We've got a Maternity Voices panel, which is a group of people with experience who work with us around how we can improve services. We've got a similar model for cancer. So there's we take a kind of a multifaceted approach to this, I guess. And I think if we look at those cold numbers and say actually 203 people fed into this process, I think it's probably an underestimate of the way that we've tried to do the business.
Okay. It is just that your report says 203 people. Councillor Hutchinson.
Yeah, thank you. Given that this is supposed to be an integrated care board, it is disappointing to hear that NHS England is saying that this plan has to just concentrate on the NHS element of the work of the integrated care board and partnership, rather than it being a properly integrated plan. But that's beyond that's decisions taken further away, so that you have no say in. I am concerned about the workforce side of things, that there's a large section about stripping Kerala and Uganda of trained healthcare staff, but nothing about growing our own, nothing about outreach and in-reach work with schools and colleges in West Yorkshire to raise awareness of careers, which is essential if we want to achieve the ambition that's set out there to have the diversity of our workforce to represent our community. In addition, there'd be no visa problems, and it would be a long-term investment in a more stable workforce locally and in the local economy. So I really don't know why this focus on grabbing trained staff from places where they're absolutely needed and in very short supply, and bringing them to West Yorkshire, which by comparison is swimming in staff. In workforce, I would also like to know whether the Workforce Observatory, whose funding stream came to an end in March, has been kept going with another funding stream, because it did sound as if they were doing some useful work. And I'm unclear from the plan what the National Information System pilot is aiming to achieve. There's some words there, but they don't actually amount to very much, which is worrying, as the West Yorkshire Integrated Care Board is the national project lead for this. So I would hope to see something a little bit, a clearer focus, if you like.
Esther, did you want to come in?
Yeah, thanks, Councillor Hutchinson. And what I was just trying to say at the start is, if hopefully you'll see in the plan that we have gone beyond the NHS, whilst we've not been able to do everything that we do as a partnership. Certainly, I don't think our plan represents solely what the NHS services are doing, because we just don't work in that way. A lot of our services are in partnership with others, but yeah, we would prefer to have something that was far more integrated. Obviously, we will keep trying to reflect it in the right way. In terms of workforce, I mean, the first thing I would say is that this document was written before the National Workforce Plan came out. I would also say that there is a lot of that work that is happening across all of our places and across West Yorkshire. And again, I think that's one we need to take away and think about how that's reflected in there. But obviously the National Workforce Plan has certainly highlighted much more about how we can work with local colleges and local people. And so that will obviously feature into the plan for next year far more. In terms of the pilot, I'll certainly take that away and try and get some information to send out.
Sorry, I didn't understand that.
Sorry, that's my watch. It's obviously not understanding what I'm saying. I'll make sure that I get some information on that pilot for the committee and ensure that's circulated around. I don't know whether there was anything you want to add about the Workforce Observatory, Ian.
Yeah, I mean, the obviously the decision around the Workforce Observatory is wrapped up in the wider conversation about running costs. We'd like to continue it because, as you say, it's doing some good work, and we've got support from partners to do that. But we'll need to review that as part of the operating model review. Just on the Kerala point, what would you've mentioned the word sort of like stripping capacity out and that kind of thing. What we're trying to do is build an ethical and kind of mutually beneficial partnership with Kerala, both in terms of what the Carolan system benefits from partnering with West Yorkshire, but also in terms of the experience of the individuals who come and work in our country as well, and making sure that they've got the right infrastructure and support around them. So it hopefully isn't this old model of we identify a country and pinch all of this staff, and we're trying to do it in a more of a planned and reciprocally beneficial kind of way, I suppose. You're absolutely right on the wider point that our workforce strategy isn't about global. Our workforce strategy is about recruiting, retaining and growing our own. Given where we are with the National Workforce Plan, as Esther suggests, I mean, I know we're limited in terms of the number of meetings we've got, but I think a conversation about what that means for us and our response to it would probably be quite helpful.
And often, and also if you're looking at things like psychiatry, where it's all done by conversation or by word, you need to have people who are clued into the nuances of language. And if you're having people where English is not their first language, that can often be missed. So there are certain specialties, maybe like radiology, where it's not so important, but psychiatry, I would say a good mastery of colloquial English is really, really essential if you're going to understand what your patients are trying to say and communicate in a way that they understand.
Yeah. Would it be helpful if we brought workforce as an item, Ian, then, so we can talk about it in more detail?
Yeah, I mean, we'd be happy to do that. I think it's your committee, obviously, and you've got a lot of stuff you want to get through the agenda. But I think from our perspective, we'd welcome that.
Yeah, we'll put that on the list. Can I just ask a final question before we wrap this up? It's about the strategy and the plans underneath it. So who monitors the plans underneath it? For instance, I went into the primary and community care plan. And when I look at that, there's a lot that are in objectives that are in progress. There are a number that have not been started. If I just pick one at random, for instance, work collaborative with mental health program to support the delivery of 75% delivery of LD health checks in PCNs by 2023, and it's down as not started, and we're in 2023. And the dental health part of that plan has objectives, but no detail against when they're going to start or anything. So who governs those delivery plans to ensure that they are working?
So, I mean, the first thing I would say is there's an awful lot of work going on in each of the primary care networks around the learning disability health checks. There's some fantastic work that's been happening and some real progress made. So I think perhaps I'm not sure why that's showing as that. We do have a number of programme boards. So we have obviously at Place, we've got the ICB Place committees that will monitor the local place plans and the delivery plans underneath that. In terms of the West Yorkshire wrapper and the the plans that are under there. So cancer, for example, their delivery plans will be overseen by the Cancer Alliance at the moment. But ultimately, in terms of the Joint Forward Plan, the Integrated Care Board has responsibility for oversight. But we do have obviously assurance and oversight mechanisms underneath, such as sort of performance committees and also the programme boards themselves that will oversee that.
Okay, all right. So we look forward to a bit more detail, I think, about some of that, and in particular about your dental health objectives, I think. Okay, so if that's all the questions, I think we'll move. Oh, Councillor Rhodes, quickly. You're on mute, Councillor Rhodes.
Thank you, Chair. That goes back to the questions we've all asked at the beginning: who monitors the monitor? Because if we've got something up on screen like that and there's something going on, well, why the dickens isn't it updated for people to know that it is happening? And I think that's a failure. But just to, in terms of the workforce planning, I'm sure you do know, and if you don't, and I'm sure it must have been discussed somewhere else other than between us, that the Mid Yorkshire Trust has actually gained approval now to set up its own training school, which is a bonus for a lot of the issues that have been mentioned today in terms of Colin's comments and ours as well. The training school at Pinderfields was always a gem in the area, and I'm looking forward, as I'm sure we all are, as to how that's going to be achieved, what the outcomes are going to be, etc., the enrolment, the recruitment and everything else. And hopefully that will be another gem in the crown of delivering of staff and people locally to get involved in the health service as well, Chair.
Yeah, thank you, Councillor Rhodes. Thanks, Esther, for that update. Can we move on then to item 8, when we're talking about harmonisation of commissioning policies, and I believe this is Catherine and Christine that are going to speak to this report, please. Thank you.
Thank you, Councillor Smage. Hello, my name's Catherine Thompson. I'm the Associate Director for Planned Care at the ICB, and I am leading the work on harmonisation of our commissioning policies. I do have some slides that I can share if that would be helpful, but it doesn't say anything that isn't already in the paper.
Okay, I think have we all read the paper that was circulated? Yeah. So yeah. I think if you just want to speak, that would be fine. Thank you.
Perfect. I'll just go through some very key points and then back over to you for your questions. So harmonising the commissioning policies isn't a new piece of work. This is something that we have been doing for a number of years, but previously it's just been done as part of, as we've done pathways of care transformation, we have ensured that any of the clinical policies within those pathways have been the same across all of the places of West Yorkshire. When we became an ICB in July and a single statutory organisation, the need to do it became more than a need but a requirement, because we can't have different policies for different people in different parts of West Yorkshire. So we needed to accelerate this piece of work and get more or all of our policies aligned. So we've been moving at pace. There are a few more to come after today, but only a few. We are more or less towards the final stages of this piece of work now. So in this current stage, we've looked at a number of policies, and there were 8 policies where we needed to harmonise the commissioning threshold or the detail of the policy, and they are listed. There's an age change in the ear correction surgery. There's a body mass index change for some of the corrective procedures after significant weight loss mainly. And there is a change or a proposed change in the prescribing of gluten-free products. And that is the one that I'd really like to focus on, because I think that is the one that will be of greatest interest and concern to you today. But I am happy to take questions on any of it. We have done involvement and engagement with the population of West Yorkshire on this. We did targeted engagement with the people who currently receive gluten-free products on prescription, and that is about 930 people across the whole of West Yorkshire, because it is only in the Leeds and Calderdale places. We had about 300 responses to that. The key points were that gluten-free products are more expensive than standard gluten-containing products, that if you are a distance from a supermarket, your ability to get hold of them is less. There are some differences, perceived differences in quality between some of the products that are available on prescription and some that are available in the shops commercially. And there were some concerns voiced about individuals' ability to afford to maintain a gluten-free diet. What did I want to say next? So we have completed a second stage of involvement, which closed yesterday. So we will be collating the feedback from that. That is more general across all of the policies and is not targeted. It is for anyone to provide feedback. We have had quite a good number of responses to that, but I'm not in a position to tell you anything about what it says yet, as that's still to be analysed. Specifically to the gluten-free element, we have also met with representatives from Celiac UK to discuss their thoughts, their concerns, and to talk through some potential mitigations and things to consider. And it was a really productive and helpful conversation. It was last week or the week before, just recent, 27th of July. And that was really beneficial to all of us, I think, to them and to us. So we will, in terms of the next steps, we will take the feedback and discuss it as a whole ICB at the beginning of September. The meeting is the Wednesday, the 6th of September, where we will consider or all come together to consider what we've heard and what we think we should do as a result of what we've heard. And then we will make a recommendation which will be taken to the Transformation Committee at the end of September for a decision.
Okay, thank you. I do need to declare an interest in that I am celiac. Obviously this doesn't affect me because I live in Kirklees, but I'm also a member of Celiac UK. Okay, so I do need to declare that interest. Can I open it up for questions? Are there any questions on this part, Councillor Addy?
Sorry, I was on the general, or just on the gluten-free, or on the general.
No, on the report as a whole. On the report as a whole.
One of the things I was looking at was the BMI statement on 27 or 30. If it went to a harmonised 27, would that allow for individual exceptions? Because I appreciate, people work very hard to get themselves into a situation where they can have this kind of surgery. So for some people that will involve, like for example, rugby players are all morbidly obese. So somebody who's down at 27 or 30 could be very different, and it might be almost their end point, or, having lost masses of weight elsewise, muscle built, they've got to that point, and their real change, or maybe the push to the next level of of change might just be that body image fixing what they've made wrong over time. Would there be a scope for individual exceptions if it went to 27?
There certainly would, and there would be plenty of sort of different reasons why that would happen. The main reason for needing to address sort of excess skin and skin folds and what have you is that they are not only a body image problem, but also a health problem in terms of deterioration of the condition of the skin, development of skin infections and ulcers and wounds, and none of that is at all desirable. And if somebody was experiencing that and had not got to the threshold for having the surgery done, it would be considered, that would be a very, very valid reason. So everybody will be taken on their merits because that is necessary. I think we went for the lower one. We had to go one way or the other. And there are most definitely health gains to be had from trying to achieve the lower BMI. There are associated risks, and there is always the ability to consider people individually. And that would most definitely be the conversation between the sort of the surgeon and the clinical team who are supporting the individual in the years of follow-up, because follow-up following significant weight loss, be it surgical or not, it requires a lot of ongoing support. So there is that opportunity to have those conversations and make those shared decisions based on the individual. So absolutely, yes.
Thank you.
Councillor Eddy, okay. Councillor Hutchinson.
Thank you. The numbers of people undergoing these sort of body reshaping procedures is quite small, 40 across the whole of West Yorkshire with the current guidelines. But I know that they can be quite a major undertaking for people who are having it done. And there, as you said, there are risks in waiting as well as risks in proceeding to earlier than you might. But the information we've got here doesn't allow us to balance those risks in terms of which would actually be the less risky option for people. And I think that would have been information that would have been very useful during the consultation. I'm sure it exists out there somewhere, even though we know that BMI is a very imperfect measure. It's a bit like GDP. It's convenient, but it doesn't necessarily tell you a whole deal. So I just wondered what clinical information about risk you actually will be putting in front of the board.
Thank you, Councillor Hutchinson. That is a really good point and a really interesting point. And the information that you are looking for is exactly the information that I was looking for too as part of this process. And whilst it is possible to bring together the information about wound healing rates, post-operative infection, ability to get mobile at different BMIs and the different anaesthetic risks and all of that, there isn't anything that can give you a compelling threshold at which the risks go up. The converse is that there are compelling benefits that it is possible to demonstrate the evidence for them of achieving a BMI of 27 rather than maintaining a BMI of 30. So it's a balance of evidence, but it isn't really possible to compare apples with apples. It is very much about taking a whole basket of evidence and putting it together.
I get the picture.
Okay, thank you. Can I ask as well, because it seems that in some cases, one case you've taken the middle position, but in other cases you've taken the lower position. So the BMI, you've got people have to go to a lower BMI. I do have personal feelings about the cost of gluten-free and the fact that, but I won't get onto those. Especially if you're a family and you're already struggling. But you just seem to have taken the lower denominator of things. So can I ask why that is? There doesn't seem to be any reasoning in this report as to why you've taken the lower denominator.
So thank you for your question. For most of the things, for some of them it is the lower one, and that is the case with the BMI, and that is, as I just explained for Councillor Hutchinson's question, it was where we landed on the balance of the risk, but it's not a wonderfully scientific and precise process. For some of the others, such as the ear corrective surgery, actually in some places that's gone up and gone down, and that was just about agreeing a single age at which we say this is the end of what we might consider treatment you would have in childhood, and beyond 18 is adulthood. So that's why we set it there. Where there were inconsistencies in ages, we have tried to do that alignment previously. It often doesn't have an age factor to it, but where there is, we've just tried to go for what would be a recognised and consistent with other policy areas, not necessarily things that are listed here. So that would be why we chose that one. And then gluten-free, it was either one or the other. There is no halfway house, I am afraid. So
yes, I know. I'm not particularly asking about the gluten-free, obviously, because I have an interest in that, but I'm asking about in general. There seems to be you've gone for the lower denominator. And is all of this balanced on risk and medical opinion? Is there any financial aspects to these decisions?
Also a very good and very interesting question, Councillor Smage. I, with the help of the finance team and some analysts, developed a framework to try and understand what the impact might be on the numbers of people who might require treatment or be able to access treatment if we raised it, or may no longer be able to access treatment if we lowered it. And what the data very clearly tells us is that having a lower threshold, a more stringent access threshold, doesn't correlate with having lower levels of activity per head of population in that place. That isn't a surprise, and the converse is true. You know, a more generous threshold doesn't correlate with a higher activity level. And that isn't particularly a surprise to me, because I have worked with NHS England over a number of years on their evidence-based interventions programme. And that is something that we discovered as part of that programme very early on. We did the mathematical modelling of what would happen if everybody went to the intervention rate of the lowest, and what would happen if everyone went to the intervention rate of the highest. And the range is fairly insignificant. I can't remember the exact figure now. I don't actually believe that anything in the threshold of the BMI or the pinoplasty, the ear surgery, will change. I don't believe we will see any change in activity levels as a result of the harmonisation, but we had to choose one way or the other of making it all the same.
All right, thank you. Quickly, Councillor Addy, because we have gone over time by some considerable amount,
sorry, yes, I thought it was
unfortunately.
2
So
hours.
if I just bring you in and then we'll move to the next item. Thank you.
Just on the celiac issue, I mean, obviously cuts are going on all around, and this is going to be a saving in that sense. But so nationally, probably it's happening everywhere. If the products that are prescribed are better or preferred than the things available in the supermarkets, is there something, I don't know what the Celiac Society has said to you, but is there some work could be done with the producers to make them more widely available, and maybe some kind of subsidized organising, and obviously it's the Celiac Society and yourselves that have been talking, but it would be nice to see people being able to access these products, and especially Councillor Mage hinted at families. I mean, people and my friends are celiac and their children are celiac, and it's a lot of products to have to go out and buy, and they are exceptionally expensive if you want to try and eat bread and stuff. And I know that they need to get people to try and use alternatives, but we all like a sandwich, don't we? Is there anything that the Celiac Society have been talking about with you that could move forward in that sense?
We didn't. Well, we had a good conversation about all these sorts of things. I have to say that when we saw that piece of feedback, that specific thing about the quality differential between prescribed and commercially available products was a surprise to all of us. And it wasn't necessarily something that Celiac UK had on their radar. We did say, if a product is better and is liked, why is it not commercially available? We do want to do some exploring on that. I wonder whether it is actually commercially available, but it isn't stocked often, because if it's better quality, it might be more expensive, and so it wouldn't sell sufficiently to be a good commercial proposition. But we are planning to find out. The point you raise about families, and that Councillor Smage raised about families, is really important, because celiac disease does have a genetic or hereditary link. So if somebody has it in the family, it is quite possible and probable that somebody else will also have it. So in families, it is likely that there will be multiple people affected. We have talked about strategies that we might be able to employ, because we recognise, particularly as you say, in the terms of the times now of cost of living crisis, that actually for the people in the worst financial situations, they can't afford to put the oven on, and they don't always have sufficient income to keep the fridge on. And being able to open a tin of something and put it in a sandwich is an instant meal. And if you haven't got bread, that becomes harder. So we
Oh dear, I think Catherine is frozen there.
We have been...
Oh, she's back.
Oh, sorry. Options for meal plans that can be made with a kettle and a microwave.
Okay.
To try and find cost-effective ways. But there are also... we were talking to Celiac UK about all the different sorts of strategies, because clearly that level of I can't afford a fridge or an oven, that isn't everybody, it isn't the majority, but we need to be able to meet the needs of all people. So the places who have already done this, such as Wakefield and Kirklees, did produce some useful resources for when they did it, and they are in the process of being shared with all of the other places. We want to see if there is more we can do, and I will say this and then sort of contradict myself. We are also even in the places where this has been happening or has been current practice for a number of years, working with food banks to try and ensure that not just a gluten-free diet, but other alternative dietary requirements are catered for. However, I recognise that going to a food bank is not a week-on-week sustainable option. It's just about raising the awareness that other dietary needs are more expensive, and having them available for people in extreme need is important.
Thank you. Sorry to cut you off there, but we are behind time. So thank you for coming in today. Can we move on to item 9, please? The work programme. Some suggestions have been circulated on the work programme. Obviously have some discussions on items that we've mentioned as far as the strategy is concerned. And we'll also have some discussions on dentistry that we've discussed and workforce. Are there any other items that the committee would like to have brought to this board? Councillor Rhodes.
Chair, are we going to add to that on a regular agenda basis the issues that we've heard today from regarding the Integrated Care Board and service outcomes and delivery plans in relation to the actions that they're taking financially? I think it's incumbent on us maybe once a quarter at least to ask the question. We ask the question and we bring the answers in a report, like we have a constant update on it. Otherwise, I think we're going to be in a situation where at the moment we're not in the game other than from today, but I think we need to be heading up the game now on behalf of the public.
Yeah, will do. Yeah. Mike, you wanted to come in?
Just to say, Chair, I've got a note of those items from the earlier discussions, and now we've elected a chair and deputy chair. I'm sure Ian will be happy to meet in the next few weeks to talk about how this fits with the timetable of work in the ICB.
Yeah, Councillor Hutchinson.
I mean, in terms of activities that the ICB are sort of taking the lead on, I seem to remember, but I can't put my finger on it, that somewhere in the plan is about coordinating the winter preparedness or the response to winter, this sort of unforeseen thing that tends to come around at 12-month intervals. If so, it would be useful to know what shape they feel that the Integrated Care Partnership is in to respond to winter.
Yeah, Ian, did you want to come in really quickly on that one then?
Apologies, Councillor Smith. I don't have to. I guess just to say, well, the winter plan is happening now. The winter planning is happening now. There's 4 chunks to it. One is around surge capacity. One is around vaccines. One is around the sort of the transformation bits like respiratory hubs, and one is about sort of system coordination and oversight. And we'll be taking that to our board in September. So a conversation after that might be helpful. But the work's being done now, Councillor Hutchinson. So. Yeah, we're foreseeing it.
Could I ask it when we get a report back? I've asked this question in other places. I was listening to a report about women's health, and in that report we had the Minister for Women's Health announce that the government had announced itself a £200 million package to improve women's health. Now, obviously, the ICB board relation to places will, I'm sure, know how much of that money you've actually received from the government and how you're going to use it to improve women's health across the patchy. And I don't expect an answer today, but if you could take that on board and let us all know, we can deal with it through our own scrutinies.
Okay, will do.
Thanks,
Councillor Swift.
Yes. Firstly, a query. GP surgery provision, is that an issue dealt with at West Yorkshire level or at place level?
I would
Place.
Yeah, go on. Yeah, place. I would have said place, but the strategy, I would have said the strategy for primary care across West Yorkshire is with the ICB, is it not, Ian? Yeah.
Okay, thank you.
Okay, thank you. Right then, so I think that closes our agenda for today. Can I thank everybody for attending, and we'll put in place some suggestions for a work programme and organise future meetings, have timetabled meetings throughout the year. Okay, thank you for attending.